going to turn it over to Sarah Lyon-Callo, who is our state epidemiologist and director of our bureau. Thanks.
Thank you, Joe. Good morning, everybody. I am the director of the Bureau of Epidemiology and Population Health, which includes communicable disease and some other epidemiology functions. Dr. Wells does send her regrets. She and I spoke last night, and if I can convey 1/4 of the enthusiasm that she has for the elimination of hepatitis in Michigan today, I will be wildly successful. She developed these slides, which, how do I get to them, Joe? Sorry. Arrow forward? Ah, there we go. Thank you, Adam. So she was unable to be here today because she does have some responsibilities in Flint, including a Mission Flint meeting that she needs to be at. But she wanted to convey her enthusiasm, as I said, for the elimination of viral hepatitis. Okay. And I am available to take back any comments, questions, considerations that you'd like to share with Dr. Wells or other people in the department. So please, at the end of the talk, please do convey those thoughts and ideas. So the Bureau of Epidemiology has an essential role in the state in terms of providing assessment functions around a variety of health outcomes. And next up on the agenda, Joe Coyle is going to be providing an overview of the 2016 hepatitis annual report. One of the things that I took away from looking at a draft of the report was that hepatitis B and C impact all of the population, impact all of us. However, the epidemiology and surveillance data are very important for understanding which subpopulations are perhaps most impacted or most vulnerable to infection. The federal government has recognized the need for surveillance, and although perhaps at times they don't always fund it as consistently as we would like, there is certainly an investment in improving surveillance and epidemiology functions around hepatitis B and C. So using these data, we can understand the magnitude of the exposure and the infection in the state, as well as diversity of different populations that are impacted. Dr. Wells very much wanted to focus around the national and international reports that are coming out and recommendations that are coming out around the elimination of Hep C. I hope this report is familiar to many of you in terms of the World Health Organization's commitment to eliminating Hep B and C through prevention and treatment by 2030. And they're viewing this as feasible. I'm sure it's a lofty goal, but they feel it's feasible. There are tools to combat hepatitis, both from a primary and secondary prevention to minimize incidence, to treat those individuals who are infected for improving their own state of wellness, as well as reducing the infectivity of population as a whole. One of the messages that comes through from the World Health Organization is understanding the need for equity, to obtain equity. So there's a concept here about prevention needs to reach the unreached. So we have a need to identify those who are susceptible to infection or already infected, but to be able to provide public health education regarding prevention in a useful and attainable way. We also have surveillance for illness can promote the use of effective treatments, including the new medicines that make it possible to launch a major testing and treatment initiative. The World Health Organization has identified 5 service coverage targets for eliminating hepatitis as a public health threat. And I'm not going to go through and read each of these, but they're important things to be thinking about today. The service coverage targets are organized in the areas of prevention and treatment. In terms of prevention, there's targets for obtaining vaccination of infants for Hep B, to reducing mother-child transmission for Hep B. There's improvements around the safety of the blood supply, as well as injection safety coverage. There's also targets set for treatment in terms of the diagnosis of HPV and HCV, as well as the treatment of HPV and HCV. I'm sorry, I forgot one of the prevention initiative was around harm reduction. So harm reduction, particularly around people who are using injection drugs. Obtaining these, meeting these targets will result in an impact in our incidence of chronic infection as well as mortality from chronic infection. There we go. Okay. The National Academies of Sciences Board of Population Health and Public Health Practice has also developed a national strategy for elimination of Hep B and Hep C in the U.S. This document provides goals, strategies, and recommendations for action, and they focus them around 5 strategic directions. The first direction is around having information for focused action. So who's impacted, where do we need to act? Second strategic direction is around what interventions are out there for impacting both incidence of the disease and treatment. The third strategic direction that recommendations are organized under is about delivering public health and healthcare services for equity. Fourth strategic action is around financing for sustainability of elimination activities. So strategic action can only take place when you have an infrastructure that enables that action and consistent funding. And that would include funding for epidemiology and surveillance, funding for laboratory, public health nursing, outreach activities, vaccination at both state and local level. Okay. Dr. Wells did want to focus in on some of the national targets for Hep B and Hep C elimination. There's an expectation that we'd have a 50% reduction in mortality due to chronic hepatitis B by 2030, and that should avert 60,000 deaths in the nation. A 90% reduction in the incidence of hepatitis C is considered possible in the United States by 2030. However, Dr. Wells wanted to make clear that one of the recommendations or the themes of this report is that meeting this goal is only possible if you have treatment without restriction by severity of the disease. And we also need to have a consistent ability to diagnose new cases even as prevalence of the disease decreases. So that will, as the disease becomes less prevalent, you have to change your focus a little bit in terms of how we identify new cases. Okay, the national strategy document has a number of recommendations, which I'll go through quickly. Yeah, I'm on the right slide. Okay. And these are recommendations for actions by federal, state, and local government, as well as health plans, healthcare provider networks, and associations. So don't worry, there's something in here for everyone. The first recommendation is that the highest level of the federal government should oversee a coordinated effort for elimination. So again, one of the ways that we maintain infrastructure and funding is if there's very high level commitment and leadership to this activity across the federal government. There's a recommendation that the Centers for Disease Control and Prevention, state and local health departments improve our case finding measures and monitoring around hepatitis B and C. And for hepatitis C in particular, they called out the need for CDC to work with National Cancer Institutes to include viral etiology to reports of liver cancer in standard national reporting. Recommendation 3.2 is an expectation that CDC would conduct both cross-sectional and cohort studies of Hep B and Hep C incidence in the United States to improve our understanding of how the infection is spreading in the country. There's also a recommendation, there's a lot of recommendations that focus around increasing equitable access to public health and healthcare services. I think you'll see that theme over and over here. But recommendation 4.1 is focused on states that states should expand access to adult Hep B vaccination and removing barriers to immunization by providing free immunizations in pharmacies and other accessible settings. There's a recommendation that CDC, ACOG, and the Association for Study of Liver Diseases and Infectious Disease Society would work together to improve prenatal testing for at-risk women during pregnancy to evaluate the need for antiviral therapy as a prophylaxis to reduce transmission. There's a recommendation that state and federal agencies should expand access to needle exchange and opioid agonist therapy in an accessible manner. There's a recommendation for CDC to work with the states to enhance viral testing, and again, with that focus on to identify settings that are appropriate for enhanced viral testing. So meeting people where they are. There's a recommendation that public and private health plans should remove restrictions on direct-acting antivirals to improve ability for people to receive care for chronic Hep C. And there's a recommendation to NCQA to add screening measures and vaccination measures for Hep B at birth to their HEDIS portfolio of monitoring measures that health plans use. Are people familiar with HEDIS? Okay, some are. Great. Okay, again, a number of these recommendations you're going to see they're really focused around improving access to care and vaccination. So there's a recommendation urging a partnership at the national level between specialists and primary care to improve treatment capacity for Hep B and Hep C in primary care, and to set up a referral system for complicated patients. It's a recommendation that the federal DHHS should work with states to build a comprehensive system of care and support for special populations with Hep B and C, sort of like Orion White for hepatitis. There's a recommendation that the criminal justice system should improve screening, treatment, and vaccination for Hep B and C according to national clinical guidelines. And the last recommendation that Dr. Wells wanted to highlight out of this National Academy report was that the federal government should make use of their buying and licensing powers to improve access to direct-acting antivirals for portions of the marketplace that perhaps have difficulty purchasing those drugs, including Medicaid, Indian Health Services, and prison systems. Okay, so these are some of the things that we thought that Dr. Wells thought would be important to set the stage for your thinking today as you hear the other presentations. How do we actualize these kind of strategies and recommendations in Michigan? Although perhaps elimination by 2030 may feel like a lofty goal, what can we do to get there within Michigan as a whole? So you want to make sure that you had a great meeting. I know there are a lot of questions and concerns around particular issues, and I will do my best to answer them, or I will get back to you with answers from Dr. Wells and other people in the department. So thank you very much for listening to me. Yes. Hi, Larry.
I'm Larry Crane. I'm an IT doc, and I work at Wayne State University. In terms of comments, there is one group in this country that most of these goals, and that's the VA system. Now, there are actually no fibrosis restrictions on veterans who are eligible in the VA system. So all veterans with hepatitis C can offer therapy. The system is negotiated with pharmaceuticals, with cost down to a very reasonable amount. What we're paying for all sorts of therapy, a single veteran, I can't tell you a number, but it is incredibly cost effective. And I know that Detroit VA, so basically, I'm talking about the VA, and the Detroit VA system has been very, very aggressive in identifying veterans that are infected and getting them into treatment. So there is a federal system that is really a model for what can be done, and it's making a great effect. As a treater, I'm finally seeing genotypes I never read about or never seen before in the VA system, particularly at a lot of genotype 4s, which we don't see much of out where I practice in Detroit.
Thank you. Any other questions or comments or things you'd like to convey?
Quick one for Dr. Ray. So is the VA also presenting, I don't have a microphone, but it should be, you can just state it. Is it the aggressive treatment policy, is there also an aggressive testing policy?
Yes.
Maybe you want to restate the question.
Yes, the question is, what about finding people that are infected and testing? And primary care providers are expected to do testing on all of their patient populations. Is this perfect? I don't think so. I don't think there is probably enough emphasis. But I think that if you look, and I don't know the percentage of veterans that have actually been screened, but I wouldn't be surprised if it's a much higher percentage than what you see out in the non-veterans population.
Okay, thank you, everyone.